Alright, so we're going to pick up now with our next section on the circulatory system part of our chapter, looking at the cardiac cycle. And so the cardiac cycle is what occurs when the heart goes through its sort of series of contractions, which also includes valves opening and closing. So now we're actually going to see where our semilunar valves and other AV valves also come into play, the atrioventricular valves as well as semilunar valves, where they come into play during the cardiac cycle. So during diastole, diastole is the period of time when the ventricles are relaxing, and so throughout the cardiac cycle, we sort of refer to things in the context of the ventricles. During diastole, the ventricles are relaxed and they are filling up with blood because the atria are contracting. During systole, that's when the two ventricles, both right and left sides, simultaneously are going to contract and pump blood out either through the pulmonary artery or through the aorta, depending on if we're looking at the right or left side of the heart, respectively. So systole is a period of ventricular relaxation, and diastole is a period of ventricular relaxation, and systole is a period of ventricular contraction. The actual sounds that you hear, if you're listening to a heartbeat through a stethoscope or something like that, the sounds that you're hearing throughout the cardiac cycle are actually the sounds of the valves as they close. Remember, the valves that we talked about, both the atrioventricular, the AV valves, as well as the semilunar valves, are one-way valves, and they are a bit like a spring-loaded sort of situation, or almost like a screen door that self-closes. And so once there is a relaxation, or once there's a lack of blood flowing through a valve, that valve is going to slam shut, and the sound that you hear through a stethoscope is the sound of that valve closing. The lub sound, when you think about that lub-dub, lub-dub, lub-dub sound of a heartbeat, the lub sound is the sound of the AV valves closing, so both the bicuspid and tricuspid valves are going to close simultaneously, producing the first sound in the heartbeat. The second sound is going to be the closing of the semilunar valves that separate the right ventricle from the pulmonary artery and the left ventricle from the aorta. And so those valves separating those two locations are going to close a split second later, creating the characteristic second sound that you hear through a heartbeat. So what we're going to look at here in this picture is kind of a progression. The range of time that we're looking at here is not very long. It's only about a second in length. The first thing we're going to consider over here is pressure. So how pressure changes throughout 1 full second of the cardiac cycle in relation to the left ventricle, since that's the most muscular and also the chamber of the heart that's involved in sending blood out to the rest of the body. We're going to focus on the left ventricle. Everything for the right ventricle will be similar, only scaled down. So the first step in the cardiac cycle would be for the two atria to contract. So both the right and left atria are going to contract simultaneously. That's going to cause an initial increase in blood pressure. Blood's going to go from the right atrium to the left atrium. I'm sorry, from the right atrium to the right ventricle, and from the left atrium to the left ventricle. I apologize. Right atrium to right ventricle and left atrium to left ventricle. Right? They're only going in that direction. So as blood goes through the respective tricuspid and bicuspid valves from the right side to left side, initially those valves are going to close as the atria relax, and that's going to cause the initial sound, the lub sound in the heartbeat. So during diastole, again, essentially the ventricles are going to be filling up with blood because atria are pumping blood from themselves into the ventricles via the bicuspid and tricuspid valves. From the two ventricles, then, blood's going to go from the right ventricle into the pulmonary artery, the left ventricle into the aorta, like we talked about a second ago. So that will be during systole, when pressure is going to increase. So during diastole, pressure in the left ventricle is very low. It has to be because it needs to fill up with blood. If pressure was high, it would be very difficult to pump blood into the ventricle. So during diastole, the ventricle is relaxed. During systole, the ventricle is contracting, so pressure is going up, 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 up. It's going to kind of plateau over here. And then a moment later, it's going to drop as that ventricle is going to relax. And during that time, you're also going to hear the second sound of the heartbeat, which is the dup sound of the heartbeat, as the ventricles relax and both of the two semilunar valves are going to close. Pulmonary artery and the aortic valves are going to close as the ventricles relax. And so at that point, we sort of repeat. We go back to the beginning. The ventricles are going to fill up with blood as the atria contract, and so forth. So we can look at it in terms of pressure. We can also look at it in terms of pressure in the aorta. And what we see in the aorta is that although the magnitude is higher throughout the initial and later steps, the overall pattern matches what happens in the left ventricle. And that's really what you expect, because blood coming out of the left ventricle is going into the aorta, so you would expect it to be fairly similar between those two places. All right, so the next step that we're going to look at here is we're going to look at the volume in the left ventricle. During diastole, volume in the left ventricle is going to be increasing. Remember, the atrium's contracting. The ventricle is relaxed, so blood is going to be increasing as we go through diastole. And then a moment later, the blood volume in the ventricle is going to decrease because the pressure is increasing, and that's going to therefore force blood out of the ventricle. And then over here, kind of in step 5, we're going to see again blood filling up into the ventricles as the ventricles relax and as the atria are going to contract. So again, this is a fairly complex little story that we have here, and it would be most beneficial if you could actually repeat this to somebody else, explain it, throw the picture up in front of you, look at the picture, explain it out loud to somebody else, make sure you understand what's happening each step of the way, draw a flow chart on a piece of paper, somehow interact with the material, get into the material, process it, don't just stare at it. At the very least, you want to quiz yourself and kind of explain it out loud to yourself. That will help you immensely. It's well worth your time and possible awkwardness when you explain it to somebody else, but it's well worth your time to help you learn what's going on during this cycle. All right, so this image, fairly similar. Again, early diastole, and both atria and ventricles are relaxed and they're filling up. Later in diastole, the ventricles are still relaxed, but the atria are going to be contracting. So a little bit later on, atrial systole, again the atria are contracting, blood's going into ventricles, and then ventricular systole is when both ventricles contract and force blood out to the lungs and to the systemic circulation respectively. All of this is initiated in a particular part of the heart that involves what are called self-excitable fibers. So in large part, the cardiac cycle is controlled independently of really just about any other system in the body. Most of the time, the heart itself determines the rate at which the cardiac cycle is going to be, or how fast the heart's going to beat, or how slow the heart's going to be, that kind of a thing. So in the right atrium of the heart, there is a group of cells known as the sinoatrial node, or just the SA node for short. And these are the cells that are going to act as the pacemaker of the heart. They are the ones that are going to determine how quickly the heart's going to beat, how slowly the heart's going to beat. Of course, there can also be input from the nervous system. You can have parts of the autonomic nervous system, both the parasympathetic and sympathetic parts of the parasympathetic, or the autonomic division of the peripheral nervous system. So remember, we've got central nervous system, we've got peripheral nervous system. Within the peripheral, we have the somatic, and we also have the autonomic, and then within the autonomic, we have sympathetic and parasympathetic, the fight or flight versus rest and repose parts of the nervous system. So for example, if you dump a bunch of adrenaline into the blood, that one of the effects it's going to have is it's going to cause an increase in heart rate. So while most of the time the heart rate is maintained within or by the heart itself, there are times at which other aspects of your physiology can also kick in and cause a change in heart rate in response to some situation. So the pattern of depolarization that takes place, and again, when you think depolarization, you want to think excitement, you want to think firing of cells. When the SA node in the right atrium fires, that depolarization is going to go not only to the right atrium, but also to the left atrium. Right? And from there, it's going to go also through a part of tissue kind of in the center of the heart. Think about it as being kind of in the middle of the heart, called the AV node. And AV is short for atrioventricular. So this is a bundle of conductive fibers that run down between the atria and ventricles, and within a relatively short time delay, it's going to cause a contraction of ventricles a moment after the atria are going to contract. But that time delay is very, very important. We'll talk about that here in a second. So the AV node, like I mentioned a second ago, is conductive tissue. The tissue around the AV node is almost like insulation, so the depolarization will not travel anywhere except through the AV node initially, and then down through the AV bundle. The AV node is where it starts, the AV bundle is where it continues down toward where the ventricles are. Once the AV bundle reaches the lower parts of the heart where the ventricles are, there are a group of fibers called Purkinje fibers, which are going to allow the depolarization to more or less surround and then initiate contraction in both ventricles simultaneously. But there is a time delay here. Right? The two atria are going to contract a split second before the two ventricles contract, and that's a really, really important concept, really important for that to happen. Because if the atria contract first while the ventricles are relaxed, then the ventricles can actually fill up with blood. And then a moment later, the ventricles contract and blood can be pushed out toward the lungs or to the rest of the body, respectively. And you want that to occur. If the atria and ventricles contracted simultaneously, then the ventricles wouldn't actually be sending anything out because they would not have had time to fill up with blood yet, and so they'd be pumping little, if anything at all, out of themselves. So there's a built-in little time delay here. The depolarization, which initially goes between the two atria, in order for it to get down to the ventricles, it takes a little bit of time. And that's what creates the split-second delay between atrial and ventricular contraction. If we look at something like an ECG or EKG, electrocardiogram sort of situation, we can actually look at the peaks involved. And so the next time you're watching your favorite medical drama, you can actually see these peaks on the EKG machining and kind of have a sense for what those might mean. When you see an EKG, the first thing you're going to see in a cardiac cycle is a first small peak, which is called P. This peak is a relatively small depolarization that's produced by atrial systole. So when the atria are contracting, when they're pushing blood into the ventricles, there's going to be a little bit of a depolarization that can be recorded on an EKG. It's a change in electrical potential across the membrane, which can be measured by an instrument and then recorded as the P part of the EKG. The second peak is big enough that it's given 3 letters, so it's Q, R, and S. And it's substantially larger than what we saw before with the P because QRS is the result of ventricular systole. And of course, the ventricles are bigger, they're made up of more cells, they're stronger, and so when they contract, it's going to be a bigger depolarization than we saw when the atria were contracting a moment ago. And then there's going to be a final peak here called T, which is called ventricular diastole. This is where the ventricles are going to be repolarized. They're going to become even more negatively involved with this electrical potential and therefore less likely to fire. So repolarization means they're not firing. It's like a little bit of a recovery period until they can fire again. It's a built-in, again, like a time delay, so that after a ventricle contracts, it takes a little bit of time before it can contract again. And that's important because we want it to fill up with blood. We don't want it to contract too soon before it's had a chance to fill up with the blood that it needs to pump out. So we can look at, we've got P here, we've got Q, R, S, and then we've got T over here, which is ventricular repolarization. So that's kind of a typical EKG sort of situation. We've got intervals here, P to R, Q, R, S, S to T. We're not going to worry about what U is, but all of those are parts that you might see in an EKG. If we look at the actual pathway of electrical conduction through the heart, it looks something like this. We have the SA node up here in the right atrium of the heart. When the cells in that SA node become depolarized, they start this wave of excitation, wave of electrical impulse traveling from not only the right atrium to also the left atrium. So they're both going to contract at pretty much the same time. So both right and left atria contract at the same time. We then see the AV node here. So this signal is not only going from the right atrium to the left atrium, it's also hitting this AV node, which is like the doorway or the gate getting the signal down into the AV bundle. So once this signal hits the AV node can transmit the signal down to the AV bundle. And again, this green layer here, this is the only part that's conductive. This other stuff, this kind of white, fluffy looking material, the septum of the heart itself, is not conductive. The only signal that can pass through here is the signal passing through the AV bundle. So eventually the signal gets down here toward the base of the AV bundle over here in number 4. At that point, the signal can pass up around both the right and left ventricles respectively to what are called the Purkinje fibers. And once the signal gets up to these Purkinje fibers, that will then cause a contraction or a depolarization of the ventricular cells to cause them to contract a moment after the atria contracted. So again, this is a process. This is not something you memorize. You have to learn this. It's like telling a story. Explain it to somebody. Bring this picture up, print out this picture, block out all these words, and see if you can tell what's happening in each one of these steps. What's going on here versus here? What are these green things called here? What are these little fibers down here? What's their job? If you can do those things without looking back at your notes, you'll be in really good shape. All right, so we talked about this before, the pulmonary arteries versus pulmonary veins. Pulmonary arteries are carrying blood from the right side of the heart out to the lungs. And again, remember, blood coming into the right side of the heart is relatively oxygen poor because it's just been out to the rest of the body. It's given up some of its oxygen to various bodily tissues, whether it's the heart itself, whether it's the brain, whether it's skeletal muscles. The blood is bringing back relatively oxygen-poor blood into the heart, into the right side of the heart, the right atrium to the right ventricle, and then eventually out to the right and left pulmonary arteries. The blood in the lungs is then going to pick up oxygen. We'll see how that works in a different chapter, but the blood in the lungs picks up oxygen and then returns it to the heart via the pulmonary vein into the left atrium of the heart. Okay. We can also then look at the aorta, which is the biggest artery in the body. So we see right away coming out of the left ventricle, we see the aorta in various branches carrying blood to the heart, to the brain, all the other parts of the body that need oxygen-rich blood. We talked before, too, about coronary arteries and the importance of making sure the heart is getting the oxygen that it needs so that it can produce the ATP that it needs to use. And we cannot overemphasize that enough. The heart itself also needs oxygen. If it can't get oxygen to make energy to do cardiac muscle contraction, then the heart's going to stop working. We talked about these two large veins as well, superior and inferior vena cava, the two largest veins in the body. Superior is draining the roughly upper half of the body. Inferior is draining roughly the lower part of the body, lower half of the body. These are carrying blood into the right atrium in a relatively oxygen-poor state so that it can eventually go out to the lungs, pick up more oxygen, and then eventually go out again to the rest of the body. We can also look at how blood pressure is measured using what's called a sphygmomanometer, which is a fancy name for a blood pressure cuff. Typically, when you get your blood pressure taken, you're given a number like maybe 120/80, which is kind of an average, pretty decent blood pressure to have. The two numbers that you get, the 120 versus the 80, are systolic pressure and diastolic pressure. So we're going to look to see how those are measured and what those numbers actually mean. But what you need to know is that the first number, the 120, in my example, is the pressure at which the ventricles are contracting. So it's going to be the maximum pressure in the heart throughout the entire cardiac cycle. It should be a bigger number. Right? It's going to be ventricles contracting versus ventricles relaxing. You expect this number to be the bigger of the two. Diastolic pressure is when the ventricles are relaxing, and so blood pressure is not going to be zero. There's still going to be some pressure, but it shouldn't be anywhere near as high as what systolic pressure is. If it's higher, then that's going to raise some eyebrows from your doctor or medical professional if they start to see it, especially a diastolic pressure that's getting too high. So we see this ratio of systolic to diastolic pressure. What we're actually going to look at next is how this actually works, how this is measured, how the blood pressure cuff actually operates. So the next time you get your blood pressure taken, you can kind of know in the back of your mind what's actually going on here. So when you look at an old school blood pressure cuff, a nurse or a PA or somebody slaps that on your arm. They inflate the blood pressure cuff. What that's going to do, you see right here in your arm, there's something called the brachial artery, which is carrying blood from your heart and eventually out to your arms, primarily, tips of your fingers and so forth eventually. This artery can be constricted if we inflate this blood pressure cuff around it. So if we inflate this enough, if we increase the pressure in the cuff so much that you see in this picture how the artery gets kind of skinny, right? It's been kind of closed off. It looks like this if you blow it up. If you inflate the blood pressure cuff to like, say, 150, which is pretty high, there's not going to be any blood moving through that brachial artery anymore. So it's going to completely seal off that artery for blood flow. What the nurse is then going to do is they're going to start to release the pressure in the blood pressure cuff while at the same time listening with a stethoscope. And so as pressure is being released from the instrument, eventually there's going to be some passage of blood cells going through that now less constricted brachial artery. It's opened up some because we've decreased some of the pressure. There's going to be sound being transmitted as those blood cells are moving through that partially constricted artery. And so that can be detected. You can hear that with a stethoscope. And so in this case, the first time the nurse started hearing any sound at all from the brachial artery was around 120 or so millimeters of mercury worth of pressure. Right, so what they'll then do is they'll continue to deflate the cuff. They're going to remember 120. They're going to continue to deflate the cuff until eventually they stop hearing sound for a second time. And what that second time of not hearing sound anymore represents is the fact that now red blood cells are flowing freely and they're not producing any measurable sound that you can hear, at least with a stethoscope. So the second time that the nurse or whoever stops hearing any sound at all, that will be the diastolic pressure. The pressure inside the artery is significant enough to push back against the 75 millimeters of mercury in the blood pressure cuff, and so blood can now flow freely. All right, so we're going to stop here, and I will start up the next section here in a moment.